So AML is a disease that approximately 20,000 patients are diagnosed in the United States. In the last 2 years, there are a lot of targeted therapies approved for AML, but still for younger and fit patients, we're still using the cytotoxic therapy. So the background for this study that we were using this immunotherapy agent to essentially combining it with the backbone of the chemotherapy, trying to break the tolerance of immune system against the cancer cells. So that was essentially the background. Can we add an oral agent, which is a special inhibitor of the IDO pathway, we call them indolamine dioxygenase, and kind of turn on your immune system against the cancer cells with the help of the chemotherapy. So this one was a phase 1 study. I believe we delivered the premise of the phase 1. So the primary objective of the phase 1 was to measure the safety and tolerability of this oral agent. The name is Indoximod, adding it to the backbone of chemotherapy. We found that there was no toxicity, essentially. We're calling it regimen-limiting toxicity. So the adverse event that we see are very consistent with the backbone of chemotherapy plus AML. We use this is a phase 1 dose escalation. We wanted to find out what is the recommended phase 2 dose or the maximum tolerated dose. We tested 3 different dose levels. We had 600 milligram, 1000 milligram, and 1200 milligram to be taken orally every 8 hours. And now we know that the 1200 milligram is tolerable and safe, and it's a recommended phase 2 essentially. So the study is a phase 1. We are still ongoing. We have our dose, but we are in the dose expansion. We want to understand a little bit more about the clinical activity of this combination of this drug with the chemotherapy. Sure. So as I told you, that the important part was the premise of the first one was the safety and tolerability, and we found that. From the clinical activity, we are very encouraged. It's very, very promising. We found that approximately 73% of people achieved complete remission in this study. And we have a almost unprecedented rate of achievement of MRD negativity, minimal residual disease negativity, post-induction, which is 86%, and post-consolidation, 100% of our patients in our per protocol population, they achieved MRD negativity. A few note is important that the MRD measurement was centralized by Dr. Mike Loken Laboratory in Seattle, and the MRD, we measured it by flow, and the level of MRD is less than 0.02%. That's very, very important because it's a very sensitive test. The second thing is very important is that our patient population, I present that today, 60% of them, they have adverse risk category by European Leukemia Net, 60%. And that is testimony by looking at 7 of our patients, they had T53, they had RONX1 or AXL1, 8 patients, and 12 patients, they had NRAS mutation. This is a very heavily cytogenetically and mutationally poor prognostic risk. So having this level of the complete remission, also with MRD negativity, is extremely encouraging. Of course, this is a single arm study. Isolating the effect of the drug is impossible, so we have to randomize the study further on. But the importance is that in a very difficult disease to treat, in this combination so far provided very significant and promising initial clinical activity. And finally, it's important that in this patient population, because this is a phase 1 study, we went after per protocol population, and the definition of that is people that they received 80% of their remission, right? Because we are after the regimen limiting toxicity. I cannot give you 1 dose of the drug, and then if you don't have the toxicity, I say, oh, my drug is safe. So you have to at least have some percentage, which is pre-specified in the protocol, people that they receive at least 80% of the population. These are the people that we can judge them if the drug caused toxicity or if we see any efficacy, we kind of like saying that it was in this population. If you have not received less than 80%, we're still keeping you for some safety study, but I don't think it's fair scientifically or clinically that we judge those patients, we call them intention to treat, but they didn't have it because of different variety of reasons, not necessarily toxicity, people withdrew consent, or they had sepsis, they could not swallow. Those people are not included either in the safety or efficacy, and that's very important to note. So that's a very good question. So this is a phase 1 study, of course, and I said that it's delivered this premise, but the important part is that, I cannot sit here and say that, we change the, how we treat AML, right? So the next step, I'm hopeful that, we can do some randomized trial. This we generated, it's safe, and the result is very efficacious. I got a lot of positive feedback from my other colleague in the leukemia community. So we are hopeful that, we do a randomized phase 2 study and we tease out or isolate the effect of this agent when we are combining with the backbone of chemotherapy.